It's unmuted. It's unmuted. Thank you so much.
I saw this last week. Can someone business because if we keep on having stuff in here, we're all going to be hurt. The reason why we have mice maybe or whatever pests we come in here. So if you're I think you're allowed to eat here, but please make sure if this is yours.
Good morning. I'm Dr. Tony Hall. I'm an internist and infectious disease specialist, and I'll be talking about peripheral neuropathy and neuropathic pain and pain in general. We're doing our pain scheme today. We're talking about really how to determine the type of pain and therefore the cause of the pain, and then we can learn how to treat different types of pain. So this is a big overview to start to think clinically. So I'll try to give you an idea of what you might see when a patient presents with pain. And that sometimes helps us as we're going through the details later in the week to retain that information more, because we have sort of a big picture view of how a patient might in real life present to us, and then kind of work backwards from there down to the details of microbiology, pathology, immunology, etc. So if you have questions during my talk, please feel free to interrupt me, and I will do my best with the technology. I think we're doing things a little bit out of the ordinary because of some constraints with technology. There we go. So our objectives today include analyzing the history and physical examination findings to determine if a given pain complaint has a somatic, visceral, or neuropathic origin, listing some causes of different types of pain, and we base the type on cause or etiology, and some types include somatic, visceral, and neuropathic pain. Develop a differential diagnosis for neuropathic pain, so what could be causing different types of neuropathic pain, describing the differences in cause between acute and chronic pain, and recommending a stepwise approach to treatment of both acute and chronic pain based on the likely source or cause of the pain complaint. Can you hear me okay? Everyone, we'll move on. Let me see if the arrows work. Let's see. So these were some examples of videos. They're TED Talks you could watch just to start to get also some additional information about an overview regarding pain. If you would like to view them, you probably already have reviewed this. So some readings too, that if you would like to become more oriented with the guideline type publications, you could read the American Family Practice Journal articles, and they're listed here. One about peripheral neuropathy, which is a very common presentation of neuropathic pain, and another about trigeminal neuralgia, which is also a common presentation of neuropathic pain that has to do with one nerve. Whereas peripheral neuropathy oftentimes refers to polyneuropathy, or multiple nerves involved. Okay, so just a broader table about somatosensory system regarding touch, pain, and temperature. So when we talk about sensation, we're not just referring to pain. So some of the other types of sensation might be involved in your evaluation of pain, such as touch sensation, temperature sensation, or proprioception, which is knowing where that part of your body is in space. So the sensation of where that limb or that organ or that part is located, if it's moving up or down. If the person cannot sense that as well, then they have a decreased proprioception sense. So some positive nerve or somatosensory symptoms could include pain. So that is not the absence of something, but the presence of something. I'm feeling pain. There's allodynia, and that should describe a type of neuropathic pain when the stimulus would not normally cause pain, like something like a feather or a sheet. So something that would normally not cause pain is causing this patient to sense pain. So that is referred to as allodynia. Hyperalgesia is that maybe that 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 input would cause pain normally, but now it's causing pain out of proportion with what you would expect the patient to sense. And hyperesthesia is if they're feeling something more than they should normally or you would expect them to feel with that stimulus, but not specifically referring to pain. So they feel more of a touch sensation or more of a vibratory sense or more of a temperature or a different temperature than you would expect them to feel. So just to kind of correct these older ways of referring to pain, so instead of referring to something as real or perceived pain, we want to talk about the pain being nociceptive. So you have nociceptors in non-nerve tissues, and if those are the receptors that are being stimulated in tissue that's not the nerve tissue, then we might refer to this as nociceptive pain. And perceived pain, where they used to say maybe this is perceived and not real, we think all pain is real when it's experienced by the patient. So instead of calling it perceived pain, we might say neuropathic pain. So the nerve tissue itself is the tissue that is experiencing the damage or the abnormality. And so that's nociceptive, non-nerve tissue pain versus nerve tissue pain or nerve pain, neuropathic origin. The cause often is not apparent. So maybe we used to call it perceived pain because we couldn't readily decide or localize which tissue was affected based on the patient's history. So this is for neuropathic origin pain. Oftentimes our labs will be normal, not always, but sometimes we'll have normal labs and also imaging. So you could do an image of a tissue where the patient is experiencing pain from the nerve origin, and you might just not see an abnormality even on detailed imaging. And so if you took a biopsy of the tissue where they're feeling the pain, you also might have normal histopathology appearance of that tissue, because unless you actually biopsy the nerve, then you might find an abnormality. Versus with nociceptive origin pain, there's more often an obvious cause or an injury. You might more often see abnormality on imaging or an identifiable cause on that tissue biopsy. So the experience of pain, just to reiterate, by the patient is influenced by the perception of the pain, but we do want to refer to pain as all pain as real pain. The only difference is the origin of the pain. So if the patient is actually sensing pain, then it's real. There are very few instances in my clinical experience of patients saying that they experience pain when they're not actually experiencing pain. So that happens very infrequently, and that would be if they had some secondary gain or goal by reporting pain. But it doesn't happen as often as you would think, perhaps. So pain, just to put these types of pain into bigger buckets, we can talk about cancer pain as separate. So if we have a known cancer diagnosis, or if we have pain, we should always rule out that there's a cancer cause or malignancy or something very serious that needs urgent treatment. But non-cancer pain we can break down into acute and chronic. Within acute and chronic, we do have nociceptive and neuropathic pain in both. So you can have longer term. Usually the cutoff would be about 3 months lasting for the pain to determine or to call it chronic. But more often in chronic pain, you might have a mixed origin. So you might have body tissues that are abnormal causing nociceptive pain and additionally some neuropathic pain. And within nociceptive pain, so non-nerve tissues are having some abnormality, you have somatic and visceral pain. So visceral would be referring to within our organs, and somatic pain would have to do with non-organ tissues like bones, joints, muscle, etc. And I know this slide is a bit overwhelming, so these aren't to be necessarily all memorized, but just to generalize that there are different causes or types of causes for neuropathic pain. So now we're just talking about neuropathic pain, not nociceptive pain for a moment. So within neuropathic pain, we can have a cause in the central nervous system or the peripheral nervous system. Within the central nervous system, tissue within the brain and or spinal cord can be affected, and some examples would include if the patient had a traumatic injury, either to the brain or the spinal cord. Thalamic pain syndrome, after a stroke or a CVA, when you have some ischemia or infarction to the thalamus itself, you could experience neuropathic pain symptoms. Or something like multiple sclerosis, where the nerve sheath is actually being attacked by our immune system and being damaged, becoming damaged. So moving to peripheral neuropathy, some examples would include, or bigger buckets, I guess, would include mononeuropathy, where you have one nerve affected, or polyneuropathy, where you have many nerves or more than one nerve, and a group of nerves that are affected. Radiculopathy is sort of in the middle. So you might have somewhere near the nerve root where there is an impingement or there's an abnormality. So there might be a small group of nerves there or one nerve root. And then based on which nerve you're discussing or how far away from the spinal cord you are in that nerve root, there are some general names like sciatica. So the sciatic nerve itself might be impinged a little farther away from where the nerve root comes out of the spinal cord. Or a brachial plexopathy, so the whole brachial plexus might be involved, and you would commonly refer to something like that as a radiculopathy. So somewhere near the nerve root is where the problem is occurring. But the bigger groups are polyneuropathy versus a mononeuropathy. Any questions? Okay, all right. So overview of the nervous system, and these again you'll review in more detail during other courses, like your anatomy. Did that skip one? Yes, okay. So just to think about very generally the nervous system, so more of like an electrical circuit type example. This is very generalized. You have external senses and internal senses, and those are brought toward the brain and spinal cord by afferent neurons. And we might call that input. So that's coming to the central nervous system via the spinal cord and to the brain where you can integrate that information. Then for output from the brain and spinal cord, we have efferent neurons, which are generally either referred to as either somatic or autonomic. And so a somatic nerve would innervate something like a skeletal muscle. An autonomic nerve, they would innervate the cardiac muscle, the smooth muscle, the glands, and either cause parasympathetic or sympathetic processes. And your symptoms could be something like sweating, nausea, vomiting. And so those are just breakdown of some groups of types of nerves that we'll be discussing later. So there are signaling molecules that would be important to know more about when you're discussing treatments. So we know that if we learn the pathways or the pathophysiology of what's occurring on a molecular level when you're experiencing pain, from there we can develop ways to target these molecules, and sometimes our treatments for pain are based on either interrupting or precipitating these pathways. So some important molecules when we discuss pain include, but not limited to, prostaglandins, bradykinin, serotonin, histamine, hydrogen ions, ATP, and then there's also physical stimulus like heat and pressure. So there's serotonin involved, you have histamine. If you look at the illustrations, you might have hydrogen ion, potassium, prostaglandins, bradykinins, and our treatments often target these pathways. So just to review the thalamic tract, the spinothalamic tract, from your input or your injury, the signal will travel up the spinal cord to the brain through the spinothalamic tract. So that's where if we're doing some procedure to inhibit the pain, they've become very sophisticated with procedural treatment of pain. So you can actually block nerves, and so they might be able to target a part of the signaling pathway through the nerve for neuropathic pain and dull that pain that way by using a procedure rather than systemic medications. So both somatic and visceral pain are nociceptive pain. Just to look at this a different way, they're both perceived by nociceptors. It's just We're just differentiating between the type of tissue where that nociceptor is located. So somatic pain usually presents. So we'll start talking more clinically now. So the patient may be able to localize the pain a little bit more specifically. So if you have a muscle or a bone those tissues are injured, the patient might be able to point with one finger and say, it hurts right here, very specifically. And that more often happens with somatic pain. And it's more the pain we're familiar with from something like a traumatic injury or an injury to the skin, muscle, soft tissue, or bone. Similar to pain that the patient has experienced throughout their life. Oftentimes that can be relieved by something like an anti-inflammatory, or if very severe and short-term, we can use narcotic analgesics to treat that. It's usually evident what caused that somatic pain, but not always. But oftentimes that is pretty obvious, like they had an injury, something that an event that they can describe to you. Visceral pain sometimes presents differently. The patient may describe a non-localized pain. So they might say, it's in this region of my body, or I feel it all across here. And so visceral pain, if there's one of the organs that's involved, so if the pain is coming from the liver itself, the kidneys, the heart, so we could include myocardial infarction patient presentation in this discussion of visceral pain. So oftentimes less localized, less well localized, and sometimes referred. So the pain from something like a gallbladder problem, we often talk about it referring to the shoulder. Some of the nerves are connected to somatic parts of our body, and so they might say I have shoulder pain, but actually this is coming from the viscera. So we don't want to rule out visceral pain until we've ruled it out by at least exam and history. Narcotic analgesics, if this is very severe, can be used, and it's usually helpful to give narcotic analgesics. You might have more autonomic symptoms with visceral pain. So more often you might experience nausea, vomiting, diaphoresis, which is sweating, different sensations of temperature in the body, just generalized malaise with visceral pain. Versus neuropathic pain. So neuropathic is different from nociceptive pain. And you might take a history and there wasn't an inciting event. So sometimes you say, well, nothing happened. I didn't have a particular injury. I mean, you can have nociceptive pain with an injury to the nerve that was acute, but sometimes it's happened over a more insidious onset, so over some more time. They can't describe a particular stimulus that causes this pain. So it may not be with a particular movement. It might just kind of be all the time. Associated evidence of nerve damage. So they might have not just pain in that nerve distribution, but they might be experiencing weakness, so motor symptoms, and other sensory impairments. They might have positive or negative sensory symptoms, like numbness, tingling, that allodynia, so some other symptoms in addition to the pain. Sometimes the neuropathic pain is more often described as shooting or electrical, burning, tingling, stabbing, very sharp, but often that electrical quality is talked about. So for instance, with tooth pain, if you have a nerve within the mouth that's innervating a tooth, that is often described as a shocking or an electrical sensation when that nerve fires and they have pain. So the difference with neuropathic pain sometimes is that narcotic medication does not help as much. So they might not be as relieved with narcotic type medication. And you might start to think that this patient has neuropathic type pain. So this is a summary slide. So it's just to talk about what we've already discussed about somatic presentation, presentation of somatic pain, presentation of visceral pain versus neuropathic pain. Some examples of causes of somatic pain might be a laceration, a fracture, a burn, an abrasion. For visceral pain, you might have a sickle cell crisis causing that visceral pain. something like colic or obstruction. So obstruction in the urinary tract or the gastrointestinal tract. Internal organ infection or inflammation can cause visceral pain. For neuropathic pain, some examples of specific presentations of neuropathic pain include trigeminal neuropathy, post-herpetic, so you had an infection that was affecting the nerve, and you have pain in that nerve distribution, that dermatome. Post-amputation, so even after the part of the body is removed, the nerve endings that juxtapose the amputation might be firing, and the patient even has sensation that that limb is still there. So they used to refer to that as phantom limb pain, but you can have pain of that residual limb. Peripheral neuropathy, so many small nerves could be affected and cause a presentation called peripheral neuropathy. And infiltration of the nerve. So some causes cause infiltration of particles into the nerve tissue, and that is causing the pain. The treatments are different for each type of pain. So we focus on the cause. With somatic pain, more often we would use acetaminophen, which treats the pain, but also non-steroidal anti-inflammatories and sometimes steroidal anti-inflammatories to decrease inflammation. So that might be part of the underlying cause of the pain. We can use heat and cold modalities more often with somatic pain because you can actually reach the place of inflammation. So if it's on a limb, an arm, or a leg, you can use heat or cold modalities to help the pain. But that is less useful or really not so useful often for visceral pain. Sometimes you can use a heating pad if the organs are close to the surface and or ice, but that doesn't work as often. More often we focus for visceral pain on muscle relaxants because the nerves firing can cause spasm in the somatic tissue, even though that pain origin is in the organ and visceral. We can use opioid medications for either one of these, visceral or somatic, but those are our last resort. We try not to. If we can relieve the patient's pain with non-narcotic medications. And when we go to neuropathic pain treatment, we have some other types of medications that work better than narcotic medications, such as anticonvulsants like gabapentin or pregabalin, carbamazepine. We have tricyclic antidepressants. So the antidepressant is not just to change the patient's mood, even though they're experiencing pain, that actually helps with the perception of pain. So we use some medications that are commonly used for mental health, we use them for pain if it's neuropathic in origin. Muscle relaxants, I mentioned, an NMDA antagonist, and you can even do a nerve block, like a neural or neuraxial blockade. So to start with our history of present illness, we want to always ask about the quality of pain. So include that question, what is the quality or type of pain? How is the pain feeling to you? And they might say some of these words like stabbing, burning, throbbing, cramping, etc. And sometimes patients don't choose these words that are on our list. So we try to decide which of those their complaint is most similar to and go from there. We can use a pain rating scale. So we can ask the patient on a scale from 0 to 10, 10 being hurts worst, the worst pain in your life. Sometimes people say 12, this is off the charts. This is the worst pain of their life. Those are good describing words that patients use. And we want to remember, in general, how we take our history of present illness, but focus on the bolded factors, like onset. Was this fast or slow onset? Were there any inciting injuries? Also the character, as we've discussed, of the pain. And does it radiate? So is this localized or radiating pain? Is it well localized or more vague in area? And don't forget the location, duration, the aggravating and alleviating factors, the timing and the severity. So an example of somatic pain is coming up next if you had a fracture. So a broken bone is a great example of a cause for somatic pain. You might also have nerve damage, just depending on the extent of the injury. So there can always be a mixed presentation, but our main problem is the fractured bone, so we would want to fix the bone. So fix the underlying cause, but also treat the patient's pain until the underlying cause is corrected. Skin, joint, muscle tissue can be the cause of somatic pain. Even something like frostbite, so you actually have ischemia or necrosis to the soft tissue and or muscle and skin. So that would be included in somatic pain. So somatic pain descriptive terms. Okay. Sharp, aching, stabbing, well localized, clear inciting incident, quick onset. Versus visceral pain complaints. These would be caused by, as I mentioned, some abdominal or thoracic or pelvic organs. So those compartments could be looked at via imaging and definitely should be examined when you have a patient presenting with pain. Even though you might initially, your impression is that this is somatic pain, let's evaluate still the organs during our physical exam and make sure that we don't have any evidence of visceral dysfunction. Some examples of visceral pain might include menstrual cramps, kidney stone-associated pain, myocardial infarction, appendicitis, cholecystitis. Any visceral organ being affected can cause visceral pain. And more often, as I mentioned, you might have autonomic symptoms with visceral pain, like nausea, vomiting, or sweating. You might have an inciting incident, but oftentimes it's just that I woke up with this pain, or this pain just started shortly after I did XYZ. That was a normal activity during my day. So it's less often associated with some event that the patient can describe. And there are fewer of these nociceptors inside of our visceral organs, and that is partly why we can less well localize the pain with visceral pain. So neuropathic pain presentation. One of the more common presentations is diabetes causing peripheral neuropathy, and that would be a polyneuropathy. You might have also impaired sensation to light touch, pinprick, and that would be in the hands and feet. They call it stocking and glove distribution. The distal muscles might also be weak. You might have hair loss. You might have generalized wasting of the muscle, the distal muscles. And you might have an abnormal plantar reflex, so we should include that in our exam as well. Some other examples of neuropathic pain I mentioned before were radiculopathy, phantom limb pain, postherpetic neuralgia. And you should also include questions about motor symptoms. So sensory symptoms, yes, but also plus minus motor symptoms. If there are associated motor abnormalities, like the patient has weakness, or that's very predominant, some of the causes might include Guillain-Barré syndrome, peroneal nerve palsy, lead toxicity, or porphyria. But just remember to ask about motor symptoms as well. And this is a photo or a drawing of dermatomes. So from the nerve root, we have what we call dermatomes, or the nerve distribution. And if you just have one dermatome affected, you might be looking at one nerve being the problem, so a mononeuropathy, versus if multiple dermatomes are involved, then we are thinking more of a several nerves, like a radiculopathy, or a polyneuropathy, if it's more diffuse, okay? And summary points of what we've discussed so far: nociceptive pain is caused by tissue injury that's non-nerve tissue. And you can see this if you do a biopsy of that non-nerve tissue. And versus neuropathic pain, where you might not have some other tissue injury where the patient is perceiving the pain, but the nerve that's innervating that area is actually damaged, okay? Or being inflamed, or being acutely affected or impinged. Any questions that have come up since we started that we want to pause and address? Okay. Neuropathic pain, some positive symptoms, again, might be unpleasant or abnormal sensation, burning, pins and needles feeling, Negative sensory symptoms with neuropathic pain, if we describe it as a negative sensory symptom, would include hypoesthesia, like numbness, decreased dexterity, so if their proprioception is decreased, they might have falls or decreased dexterity. And you might have autonomic symptoms with neuropathic pain as well. So that's not just reserved for somatic or visceral nociceptive pain, but with neuropathic pain you can also have autonomic symptoms like dizziness if those nerves are affected in the central nervous system, or your proprioception is off. Early satiety, so if nerves associated with the GI tract are the problem, then you can have sensation of nausea as well. And you might have loss of deep tendon reflexes or motor weakness. So when you're evaluating, so to discuss physical exam, we talked about still examining our visceral organs whenever we're evaluating a patient for pain. We can also focus on the neurologic exam and decide based on neurologic exam if there's a single nerve root, multiple nerves, or a peripheral nerve plexus, like in radiculopathy sometimes that is involved while doing our neurologic exam. We want to ask about associated nervous system complaints like speech difficulty or vision difficulty. We might think that might lead us to think of a central nerve dysfunction. Deep tendon reflexes and muscle tone. So we want to check the deep tendon reflexes, check a strength exam, as well as a sensory exam. Do they have loss of vibratory sense? So we can use this tuning instrument to check for vibratory sense. And if so, then that's more often associated with a peripheral nerve lesion. And the types of cells in the spinal cord, just to refresh our memory, the anterior horn cells would be what is affecting our skeletal muscle and strength, motor function, versus the dorsal root ganglia, which are involved in sensory input and would be the area of the cord involved for pain and numbness, versus the autonomic system. And if you have autonomic dysfunction, again, you can have constipation, gastroparesis, nausea, vomiting, urinary retention, orthostatic hypotension. So the nerves that innervate our blood vessels and tell the blood vessels to constrict or dilate. If those nerves to the blood vessels are affected via the autonomic system, then you can have dizziness upon standing, for instance. So you might not, your blood vessels might not respond quickly enough. So they call that orthostatic hypotension if you arise or sit up from lying too fast. And your blood vessels can't respond quickly enough to keep the blood supply to your brain, you might feel dizzy. So that can happen based on autonomic symptoms. History or trauma. Important history and physical exam points are ask about, in addition to the history of present illness, other parts of our history, like exacerbating and leaving factors, timing throughout the day, social history, like high-risk sexual behaviors, history of drug use, and specifically IV drug use, alcohol history, surgical history, and any other medical problems, including a medication list. So we do want to know which toxins the patient may have been exposed to in addition to prescribed medications and also over-the-counter medications. And that's because sometimes those medications can cause a neuropathy or a neuropathic pain. Specific medications, I'll in the next slide go over with you, and specific types of medicine, big groups of medicine, are more commonly associated with neuropathy or neuropathic pain than others. You might have, on the flip side, some vitamin deficiency. So if you're deficient in thiamine, B12, folic acid, or vitamin B6, or you had too much vitamin B6, you can experience a polyneuropathy or neuropathic pain. So we want to know about the medications and also other over-the-counter substances the patient might be ingesting, including toxins like alcohol. So under polyneuropathy, I think this makes the most sense to talk about nutritional deficiencies versus they got a toxicity from too much of a vitamin or a medication, or it's an adverse effect, a known adverse effect of a medication. Infections. So I'm an infectious disease specialist, and I see a lot of neuropathic pain. I see it every day. And so I see a lot of patients who live with chronic infections, so like viral hepatitis, like hepatitis B or C, living with HIV, and taking the medications associated with those diagnoses. Sometimes, pretty often, patients complain of pretty commonly peripheral neuropathy, but sometimes a group of nerves is bothered. Certain infections like herpes infection that reactivate, herpes viruses, like HSV, herpes simplex, and also varicella zoster virus, which causes chickenpox. If that virus reactivates, you can have a one nerve, so mononeuropathy, involved causing pain, or a few nerves that are coming from that nerve plexus. So something like shingles. Have we heard of shingles? That's a syndrome associated with reactivation of varicella zoster virus, the chickenpox virus. And that, unless the patient is immunocompromised, is often limited the symptoms to one dermatome, or one nerve distribution, or a small group like a nerve plexus distribution. It can be disseminated, and that's a big problem. The patient's immune system was not able to limit the infection reactivation to that nerve root. But in an otherwise healthy patient, most often it's limited to one nerve or a small group of nerves, where you have a rash associated in that part of the skin and a lot of burning sensation type pain, sometimes electrical quality. So infections, chronic and acute, or reactivation can cause neuropathic pain. Also remember, and this is why sexual history is important, that syphilis and HIV infection can cause nerve symptoms. One of those, being more would be chronic, the HIV infection, but it can be an acute presentation, as well as syphilis. So you can have syphilis for a short amount of time, or it could have been something that the patient contracted decades ago and just has never been treated. So you can have nerve symptoms way down the road from syphilis as well. Toxins can cause a polyneuropathy. Metabolic situations like diabetes mellitus, which is, like we mentioned, a very common presentation, and also thyroid dysfunction. So we want to check a thyroid level if we see a patient with a polyneuropathy. That's one of the first things we usually check, in addition to some of these nutrition levels, these vitamin levels, and ask your history about your social history. Do they drink? Do they have risk for any of these sexually transmitted infections or injection-related infections? Other causes of polyneuropathy could be a demyelinating polyneuropathy, monoclonal gammopathy, so there can be deposition of certain substances into the nerve that causes a more diffuse problem, polyneuropathy. Amyloidosis is a problem of deposition into the nerve. A paraneoplastic syndrome, so that's the patient might have cancer, but we didn't diagnose sometimes the cancer yet. We just have the patient presenting with nerve pain. So we have to keep a very broad differential when we see a patient presenting with polyneuropathy and neuropathic pain, and also mitochondrial disease. So still under peripheral nerve dysfunction, we can have a mononeuropathy or a radiculopathy, which we mentioned before. Versus a central nervous system problem like a multiple sclerosis, a thalamic pain syndrome, or a trauma to the central nervous system. So again, some infections that can cause neuropathic pain include syphilis, Lyme disease, mycoplasma, West Nile virus, and leprosy, but that's not a complete list. There are other infections that can cause neuropathic pain. Nutritional abnormalities like these specific vitamin deficiencies, but something like celiac disease or a malabsorption syndrome can lead to the vitamin deficiencies. So think about, is the GI tract, are they absorbing those important substances via the GI tract? Some groups of drugs, so as I mentioned, I'll just tell you the groups of drugs. These specific medications, I don't think you need to memorize, but anti-infection medicines, so antimicrobials or antiretrovirals for HIV infection, are more commonly associated with neuropathy, and anti-cancer drugs and transplant medications. So those are kind of some big groups of medications that can cause neuropathic pain and neuropathies. Metabolic problems, we mentioned, like diabetes and thyroid dysfunction. Toxins, including alcohol, but less commonly heavy metals like mercury, thallium, lead, and those deposition disorders. So do read about trigeminal neuralgia or watch those videos as an example of a mononeuropathy. So the nerve affected with trigeminal neuralgia is cranial nerve 5. And like with many neuropathic pain syndromes, we treat with a non-opioid, not Tylenol, not acetaminophen, not anti-inflammatory medication, but alternatively we use an anticonvulsant medication, carbamazepine, which is also sometimes used for mood. So that would be the difference in how you can see how that our cause drives our treatment. I mentioned shingles before. It happens in patients more often who are over the age of 50, but not always. It's a reactivation of the varicella zoster virus. And this I'm using as an example of a neuropathy where we would treat the underlying infection and additionally gives an anticonvulsant like gabapentin to treat the patient's symptoms. So carpal tunnel syndrome is just one more example of a mononeuropathy affecting the median nerve, and the treatment would include physical modality like a splint to the wrist to actually physically open up the tunnel where the nerve is passing through, in addition to medications. You can diagnose carpal tunnel syndrome with a couple maneuvers on physical exam. You can tap on the median nerve. You can use a prayer position for the patient's hands or upside down, the Phelan's maneuver, and press the hands together. And if that elicits the pain, then you would be pointed to carpal tunnel syndrome diagnosis. Sometimes surgery is used for this mononeuropathy and others, as well as nerve blocking procedures. Toxin-induced polyneuropathies again include exposure to too much glucose, like with diabetes, alcohol, chemotherapy, heavy metals, or viruses. Vitamin B12 deficiency. Some symptoms that are specific to vitamin B12 deficiency include swelling of the tongue, also known as glossitis, megaloblastic anemia, so you can have some clues to specific vitamin deficiency, and additionally you would see your peripheral neuropathy. You can help the patient by sometimes orally replacing the vitamins that they're missing, but if they're not absorbing, you could give them intramuscular or intravascular, so peripheral administration of bypassing the gastrointestinal system so that the level of vitamin would normalize. A monoclonal gammopathy, like so can lead to multiple myeloma, can lead to amyloidosis, Waldenstrom, macroglobulinemia, but this is less clinically apparent, usually the MGUS or monoclonal gammopathy of undetermined significance, but the patient can experience peripheral neuropathic pain. So we want to do some laboratories to evaluate and rule out these less obvious diagnoses as causes of pain. Electrodiagnostic studies we can do if you have this in your office, like a neurologist may have access to nerve conduction studies. You can sometimes order this in medical systems to be done to evaluate the patient's pain. Nerve conduction study or electromyography. So one is looking more at the nerve conducting the signal to the brain versus the EMG or the electromyography, which looks at the signal going down to the muscle. So we would include blood tests or laboratory evaluation in our workup for patients who present with pain, but mostly we're focusing on physical exam and history, which we have discussed a lot so far. But for lab studies, we know that we need to look at some of these vitamin levels We can evaluate if the patient hasn't been forthcoming. Sometimes we can evaluate their alcohol level if we don't trust our history. We can check a thyroid stimulating hormone, a glucose level, and a hemoglobin A1C, which gives us an average of someone's sugar. That is part of the ongoing evaluation for people living with diabetes. These other labs that are mentioned here, a complete blood count is important. If the patient has an associated anemia, we might think of something like B12 deficiency or thyroid dysfunction. So there's some crossover with anemia and some of the deficiencies that cause neuropathic pain. A complete metabolic panel, which includes a glucose level, protein levels. So you can look for evidence of malnutrition. You can look on the flip side for evidence of diabetes. And other electrolyte abnormalities. The ESR is a non-specific inflammatory marker. There's also something called a CRP, a C-reactive protein, and they're just showing us or telling us if there's inflammation, an inflammatory process. It's very general, but it's sometimes good to, if you have a normal level, then you think less about inflammation happening on a grander scale. So it's like a rule-out type test. Vitamin B12 level, in addition to folic acid, which I mentioned, B6, thiamine, which is B1, you can test. You can also, based on their risk factors, test for infections. And I think for all adults in my field, I want adults to be tested for HIV. It's very easy to test. You don't need a specific permission. You can discuss with the patient, I'll be testing this. But doing screenings at least once a year for adults who are sexually active and or have that injection risk factor for injection drug use or tattoos outside of a controlled setting, or some injury that they experience, blood exchange, even occupational exposure. Someone worked in the healthcare environment and had a needle stick. Want to make sure we check for HIV and viral hepatitis. Hepatitis C and Hep B can be sexually transmitted as well. We don't think about that as often, but they can be. Check for syphilis. Ask about a history of insect bites or potential exposures being outdoors to tick bites, because Lyme disease can be tested in labs if you have any indication that they could have been exposed to Lyme. Heavy metal exposure, so occupational history. Have they been working in an environment where they might have been exposed to toxins like heavy metals? Do they have a history of porphyria, or do I need to check for urine electrophoresis or serum electrophoresis? And that's how we begin to diagnose those syndromes I discussed before, like monoclonal gammopathy, multiple myeloma, amyloidosis. These are our initial testing, the urine electrophoresis and the serum electrophoresis. And be always thinking that there could be an occult malignancy. So there could be the patient presenting first with their neuropathic pain or their neuropathic symptoms, and they have yet undiagnosed cancer. So let's be keeping that in the back of our mind as part of our differential diagnosis, and asking about risk factors for cancer. So family history of specific types of cancers, exposure to tobacco. So not just cigarette smoking, but also smokeless tobacco exposure, the patient's other comorbidities, and even obesity. Sometimes we say the patient has no medical problems, but actually their BMI is outside of the normal range. And we know that some cancers, like specifically I can think of colon cancer, could be associated with obesity. So that is a medical problem that we should consider in our when we're evaluating the patient for cause of pain. And if they have risk factors for lung cancer, by other types of smoke or inhalations, just continue to think about the patient possibly having an underlying pain or paraneoplastic syndrome. We try to reserve our opioid medications for cancer pain if possible, or very short term after surgery or an acute injury. Oftentimes for cancer pain, they are used, though, the opioid narcotic medications. But we want to additionally include other modalities like non-narcotic medications and things like physical therapy, counseling. So let's be thinking broadly about the patient's mental and physical and spiritual health, especially when it comes to cancer pain, but with any type of pain. So if the pain is not just acute, but it's persisting, we might also add an opioid, but we try to avoid that and treat the underlying cause for chronic pain. So is it primarily an inflammatory process of somatic tissue? Is this a neuropathic pain? And we have those other medications we can use. And then try to reserve opioid medications for uncontrolled pain, even after you've employed all of your options, like a nerve block and physical modalities and other medications. Number one, always remove the offending cause and then look at your other modalities for pain treatment. Rest, ice, compression, and elevation are simple things that can be used for somatic pain specifically. And we're trying to reduce swelling and with a goal of reducing the pain secondarily. Remember non-pharmacologic treatments in the treatment of pain. Massage, heat, acupuncture, meditation, yoga, aromatherapy, music therapy, reflexology. Treating the patient's mental health as related to the pain. Not blaming that they have a mood disorder and that's why you experience pain, but just treating the patient as a whole. So we want to make sure that they're treated because we know pain can affect our mood and vice versa. So cognitive behavioral therapy, even transcutaneous electrical nerve stimulation, laser therapy, exercise, occupational and physical therapy, and spinal manipulation can help, especially for chronic pain. Local anesthetics are good for acute and chronic pain, so we want a longer lasting block of the nerve for chronic pain, but for acute pain, we can use lidocaine or bupivacaine to numb the area for the short term, especially with somatic pain. Something like acetaminophen can be used as long as we're not exceeding doses, and usually try to limit this to not a super long-term course because we know this is processed through the liver, but for acute pain is very useful. Using acetaminophen in conjunction with an anti-inflammatory is starting to replace the use of opioid narcotic type medications, because we've seen there have been some head-to-head studies that look at pain relief from using the combination of acetaminophen and anti-inflammatory as working just as well as giving that patient a narcotic medication. So that's really hopeful information that can hopefully prevent those people who might be at risk for becoming dependent or interested in using opioids long-term for other effects, right? So protecting our patients by giving them other medications. Anti-inflammatories can be steroid or non-steroidal. They can be biologics, like tofacitinib. Methotrexates are non-biologics, so that's for more chronic inflammatory autoimmune disorders that we use those. But for short-term, we use either a steroidal or non-steroidal. They can be given by different routes, so if the patient needs relief quickly for steroids and opioid medications, we have injectable medicine. So if the patient is in the hospital and acutely needs something intravenously or intramuscularly for pain relief, we can give that. Or we can give them in an outpatient setting if they're longer acting. Remember your adjunctive therapy, like antidepressants, like a tricyclic antidepressant, and an example of one of those is amitriptyline. Another example of an antidepressant that's used for pain is duloxetine, which is a serotonin norepinephrine reuptake inhibitor. You can use anticonvulsants like gabapentin, pregabalin, or carbamazepine for neuropathic pain. For somatic pain, anti-inflammatory might be more effective than it is for visceral pain. And again, remember that neuropathic pain, you can use an opioid, but it sometimes is less effective than using one of those specific medications for the nerve pain. I know I'm running low on time. I'm almost done. So chronic pain, we want to differentiate between cancer-related and non-cancer-related pain. It's very common for patients to present with chronic pain. So in developed countries, like 41% of visits might be related to some chronic pain. And it's associated with these common things like heart disease, stroke, and diabetes. So you will see it a lot. Remember to ask questions to decide if this is nociceptive or neuropathic pain. Get the story behind the pain. So spending a couple more minutes with a patient can go a very long way when you go into your clinical environment. Look at their history. So sometimes the patient is unable to give us as much history as we would like, and we have at our usually are able to access records to look at previous evaluations and treatments. And remember the effect the pain is having on the patient's life overall. So very infrequently do patients, say they have pain and they don't. So believe your patient and be sympathetic to their the effect it's having on their life, either in the short or long term, or both. And emotions become more and more involved when it comes to chronic pain. So the longer you're living with pain, the more your mood should be affected. That makes a lot of sense. And so we then think about more their mental health, make sure we're evaluating for depression and or anxiety, and vice versa. If the patient has depression, if they're in an unsafe situation, like abuse situations, chronic stress, then they might perceive their pain differently, so more or less severely. So some people, they're kind of numb to their pain because of all the other emotional trauma and stress that they're under, versus they might be more sensitive to physical pain based on their history. So we want to incorporate the questions about emotional and mental health. And I will wrap up. These are just some summary slides at the end, and I appreciate all of your attention. Any questions now that we've gotten through the slides? Yes. Right. That's pretty common. So a patient who has been living with long-term diabetes mellitus, either type 1 or type 2, you might notice hair loss, especially on the extremities, especially lower extremities. And I don't know if the toxicity from the high glucose, so controlled versus uncontrolled diabetes, there's a big difference. So the person has always been controlled. You'll see less effect physically, but if they've had uncontrolled diabetes, they'll have microvascular damage, small nerve fiber damage, and I guess that leads to the hair loss. So that's a good sign to look for patients having lived with uncontrolled diabetes for a while. And they might also have decreased pulses, so you want to check your pulses and your reflexes for those patients. And they might complain of total numbness, like they have those negative sensory symptoms. But before the numbness, maybe they have hyperalgesia and allodynia, so they have more positive sensory symptoms. So what I've seen in my experience for patients with chronic infection as well, initially when there's inflammation, they might experience the more positive symptoms, versus later stage, then you kind of have the numbness and you're prone to the injury from not knowing where your foot is or what you've stepped on or what what has injured you. They don't feel that injury can lead to chronic ulcers, deformity of the bones, the foot bones. So that's a good question. I don't know the exact mechanism, like how the hair is lost, though, just to give you an example of something to look for in an exam. Any other questions? Okay, so I can kind of summarize your question. So we were wondering if there was something just age associated without considering the comorbidities or these other causes. I would say in general, no. I mean, so there might have been some more insidious thing happening during their life, like they had high sugar that we didn't diagnose, and then now they're back in normal sugar range. But I would say I wouldn't blame it just on their advanced age. So for the geriatric population, I would still look at all these other potential causes. And usually we can pinpoint at least something that's modifiable. Yeah, right, exactly. Thank you. Any other questions?
For the deposition disorders, there was one of them, I forgot the name of it. It started with an M. I was just wondering if you could elaborate more on that.
Started with an M. So was it the mitochondrial?
I think it was before that one. You went through like several of them on the scheme. I think it was
Waldenstrom's macroglobulinemia.
Did you say to say it? Yeah, that one.
Monoclonal gammopathy?
Yeah, that one.
So components of our immune system, I know, I'm just going to do this at like a high level. I want to keep it pretty light. But the parts of our immune system, components of our immune system, like immunoglobulins, might be, if there's a spike, like there's a higher level of one type of immunoglobulin, it's like a cancer. So your cells are producing too much because of a mutation of a component of the immune system, and so it almost becomes like a toxin, like there's too much of it. So that can deposit in the nerve endings and cause neuropathic symptoms in general. Okay. I'm not asking you questions like very minutely about that disorder. We're just trying to think broadly about that could be like a blood disorder that the patient has, and that's the whole problem. So when you treat that cause, they'll feel better. Okay.
Yeah, that will be on Unit 4 in spring.
I know. So think cancer, think autoimmune disorders, think about nutrition, think about infections. So lots of things can cause neuropathic pain and neuropathy in general. Okay. Because we're kind of more familiar with somatic pain. We're like, oh, something's broken, I'll fix that bone, muscle, etc. But neuropathic pain is something that we don't think about as much in layman's terms and in our general life. So that's something we need to focus on. What else? No? Thank you for your patience. We got started a few minutes late, so I'm glad that you all could stay to hear to the end. And feel free to reach out, Dr. Arenas and I, if you have any questions, okay? Thank you.
Well, let's give her a big hand. Very nice overview. Okay, the next topic will be sensory pathways. I want you to link on what Dr. Hall mentioned about this somatic and the visceral pain, because Dr. Mocha will give you the idea how this pathway will, remember,